Today we will learn cavernous sinus. Its definition, its size, what is the dimension, what is the relation, and what is the tributary, its communication, and the applied anatomy. Now, what is cavernous sinus? It is one of the true dural venous sinus. What do you mean by true dural venous sinus? And what do you mean by dural venous sinus? That venous sinuses which is enclosed within the dural fold is called dural venous sinus. And what is true when it is enclosed within the meningeal and the endosteal layer of the durameter. First, there is endosteal layer of durameter which is very much adhering to the skull bone, and after that there is a gap in which this vein runs, and the meningeal layer is after that space, and in between the meningeal endosteal externally and the internally meningeal, the dural venous sinuses are enclosed. And the true when it is enclosed within the endosteal and the meningeal layer. But all the dural venous sinuses are enclosed within these two. But except there is inferior sagittal sinus and the straight sinus is. Okay. So cavernous sinus is a true sinus as it is enclosed within the endosteal and the meningeal, not false like the inferior sagittal sinus and the straight sinus. Okay. Now there are how many dural venous sinuses? There are 8 paired and 7 unpaired. 8 is an even number, so it will be paired. Just to memorize, 8 paired and 7 unpaired. 8 paired are the cavernous sinus, then superior petrosal sinus, inferior petrosal sinus. These two cavernous sinus, superior petrosal sinus. This superior petrosal sinus, inferior petrosal sinus, transverse sinus, sigmoid sinus, and then the sphenoparietal sinus, petrosquamosal sinus. And this is sphenoparietal sinus, petrosquamosal sinus, and this is middle meningeal sinus. These are all paired one. And what are unpaired? Unpaired venous sinuses are anterior intercavernous sinus, posterior intercavernous sinus, superior sagittal sinus. Parallel to that there is inferior sagittal sinus, and then basilar plexus of vein. This one, the basilar plexus of vein. All these are and also superior sagittal and the straight sinus and the occipital sinus. All these are unpaired one. Okay, and what is there any difference between the dural venous sinuses and other venous system of the body? Because there is no tunica media in the veins of the dural venous sinuses, and as well as there is no valve, so there is to and fro movement, and either way the blood can flow. These are the two characteristics. As well as the dural venous sinus not only receive the deoxygenated blood from the brain, meninges, orbit, ear, through the also from the face through the emissary vein, through the skull through the diploic vein, through the cerebral vein from the brain. They receive deoxygenated blood as well as the CSF, cerebrospinal fluid, through the arachnoid granulation. CSF is produced by the choroidal plexus and is excreted into the dural venous sinuses, mainly the superior sagittal sinus, through the arachnoid granulation. Okay, so that's why it is also different from other as it's give way to the deoxygenated blood as well as the CSF. Okay, now coming to the cavernous sinus proper. As I have said earlier, it is a true dilated venous sinus, so it is enclosed within the, this is the endosteal layer of the durameter in white color. This is endosteal. Here it is also continuous and then this one, it is continuous here, like this. It is firmly adherent to the skull bone. And now this is the meningeal layer of the durameter in black color. Here it forms a space in which the cavernous sinus lies. This in blue color plastic is the cavernous sinus. Why it is called cavernous? Because it presents a many trabeculae inside, which is in Latin known as caverns. That's why called cavernous sinus. Gives honeycomb appearance. There is a septate structure inside. Okay. Now, what is the relation? It lies in the middle cranial cavity. Anteriorly it is related to the apex of the orbit. This is orbit in which the eyeball lies. So apex of the orbit and the superior orbital fissure. This is superior orbital fissure. So apex of orbit and the superior orbital fissure. Posteriorly it is related to the crus cerebri. This is midbrain. The anterior part is the crus cerebri as well as the apex of the petrous temporal bone. Both anteriorly and posteriorly one apex. Anteriorly there is apex of orbit and posteriorly there is apex of petrous temporal bone. Okay. Now coming to the lateral relation. Laterally it is related to the cavum trigeminal. It is a fold. It is also known as Meckel's cave. It is a dural fold which contains trigeminal ganglion. So cavum trigeminal, and laterally it is also related to the uncus of the temporal lobe. Here lies the cerebral hemisphere and here lies the uncus of the temporal lobe. There are frontal lobe, parietal lobe, occipital lobe and temporal lobe. In the temporal lobe on the medial side there is uncus. Okay. Now superiorly it is related to this is optic tract, going to the optic nerve. Optic tract is what this is, optic nerve, and the optic tract, then it form optic chiasma, then optic nerve. Okay, so superiorly it is related to optic tract, the olfactory tract. Olfactory tract, internal carotid artery. This is internal carotid artery, and the anterior perforated substance. These are the fine capillaries which are coming from the inferior surface of the temporal lobe of the cerebral hemisphere into the in relation with the superior aspect, anterior perforated substance. So in superior relation there is optic tract, olfactory tract, internal carotid artery, anterior perforated substance. Now in the medial relation, this is our cavernous sinus. Medially it is related to the sphenoidal air sinus. This is body of a sphenoid within which lies a sphenoidal air sinus. There are two in number. I have not made septa in between. So this is sphenoidal air sinus and this is our sella turcica which contain pituitary body. Pituitary body. Pituitary gland, okay, or hypophysis cerebri. So in the medial relation is sphenoidal air sinus and the hypophysis cerebri. And what is in the inferior relation? Inferior relation there is foramen lacerum which give way to the not through and through, but give way to the internal carotid artery, through which internal carotid artery just passes through the carotid canal. It is going foramen lacerum, then coming out in the middle cranial cavity. So beneath that there is foramen lacerum, and there is a junction of the body of a sphenoid and the greater wing of a sphenoid. Okay, it is also in inferior relation. And superior we have discussed. Okay, and I've forgotten the size, the dimension of the cavernous sinus. It is 2 centimeter into 1 centimeter. Okay, now coming to the tributaries. The cavernous sinus receive from deoxygenated blood it does not contain any valve, but there is a flow, blood flow inside. When there is one flow, one side flow, there is from anteriorly and from superiorly and for lateral aspect, the blood are coming into the cavernous sinus, then it is going posteriorly. Whereas there is no the valve inside the inside the dural venous sinuses, but there is a one established blood flow, as it is coming from the anteriorly, from superiorly, from laterally, and going posteriorly to the and finally to the internal jugular vein. Okay, now what is the tributary? From anterior aspect, the tributaries are this is central vein of retina. Is from the optic canal it is coming, superior central vein of retina, then superior ophthalmic vein from the superior compartment of the superior orbital fissure. Middle compartment is made by the common tendinous ring, where it is crossing the superior orbital fissure. This is the common tendinous ring. Okay, from the superior compartment is superior ophthalmic vein and the inferior ophthalmic vein. Anterior tributaries. The laterally, this is the anterior trunk of the middle meningeal sinus, then sphenoparietal and then petrosquamosal sinus. From laterally it is receiving deoxygenated blood, and from superiorly it receives blood from the superficial middle cerebral vein. This is the superficial middle cerebral vein, and this is anterior vein of Trulando and the anastomotic anterior anastomotic vein of Trulando, and this is posterior anastomotic vein of Labe. So from the in superior relation, it is receiving blood from the superficial middle cerebral vein, and this is inferior cerebral vein. They are many in number. This is, and superficial middle cerebral vein, there are two in number, one on each side. Okay, I have made only one side, not this side. Okay, right, the right side. So it is receiving the oxygenated blood from here, and now it is passing backward, down and out like us. Now come to the communication. It is communicated to the sigmoid sinus. This is the superior petrosal sinus. This one is superior petrosal sinus, and this is inferior petrosal sinus. This is inferior petrosal sinus. So from superior petrosal sinus, it is communicated to the sigmoid sinus. This is sigmoid sinus, accept sigmoid sinus here. And from the inferior petrosal sinus, it is communicated to the internal jugular vein. This is internal jugular vein. Okay, now it is communicated to the pterygoid plexus of vein through the emissary vein. This is emissary vein. This one is emissary vein, which is passing through love, that is the foramen lacerum, foramen ovale, and the foramen vessalius. It connect the cavernous sinus with the veins of the face, that is the emissary vein, and it is going to the pterygoid plexus of vein, which is communicated to the deep facial vein. Deep facial vein is also known as anterior division of the retromandibular vein, which communicates with the facial vein to form the common facial vein. So it is communicated to the pterygoid plexus of vein through the emissary vein. It is communicated to the through the superior ophthalmic vein. This one is superior ophthalmic vein. It is communicated to the angular vein. Angular vein is the terminal part of the facial vein. So it is communicated to the angular vein, through which it is connected to the facial vein. Okay, this is the facial vein. And it is communicated with the internal vertebral venous plexus. This is the internal vertebral venous plexus through the maxillar plexus of vein. And through this is superior sagittal sinus. It is communicated to the superior sagittal sinus through the superficial midcerebral vein and the anterior vein of Rolando. It is communicated to the transverse sinus through the, and this is the posterior vein of Labe, and this is the anterior anastomotic vein of Rolando, okay, through which it is connected to the transverse sinus. So these are all communications. Now coming to the applied anatomy. There are two main applied anatomy, that is the cavernous sinus thrombosis and the cavernous fistula. First, coming to the cavernous sinus thrombosis, in which thrombosis occurred in the cavernous sinus. One thing I mentioned, I left, that the content of the cavernous sinus. The cavernous sinus internally, the lateral wall of it bears, this is in the lateral wall from superiorly to inferiorly. This is third cranial nerve, then fourth cranial nerve, then the ophthalmic division of the trigeminal nerve, and then maxillary division, that is 5A and 5B in the lateral wall of cavernous sinus. This is the lateral wall, and inside there is internal carotid artery. Here you can see this is the internal carotid artery which is coming out from the superior aspect also. This is the internal carotid artery, and there is also, this is the abducens nerve, and the from medial to lateral there is CAT, that is the carotid artery, then A for abducens and T for trochlear nerve. So it is in line with the fourth cranial nerve. This is the fourth cranial nerve. So abducens is in line with that. Okay, this is the internal content of there. Now coming to the cavernous sinus thrombosis, in which the thrombosis occur in the cavernous sinus, inside the cavernous sinus, but how it travel through the dangerous area of the face, to the cavernous sinus, by which means through the facial vein. Facial vein is draining the area, dangerous area of the face, that is the rectangular area in between the root of the nose and the upper lip. That area, the philtrum, the root of nose, some part of the ala of nose, and the corner of the lip, that much of area is the dangerous area of face. And from there, the infection, which type of infection? There can be infective agent like the streptococcus, staphylococcus, pneumococcus, as well as there can be neoplasia like craniopharyngioma, pituitary adenoma, meningioma. This type of infection travel to the cavernous sinus through the facial vein, to the angular vein, through the superior ophthalmic vein to the cavernous sinus, or it may travel, this facial vein, we all know that it combined with the anterior division of the retromandibular vein or deep facial vein. So this is also known as the superficial facial vein. Superficial facial vein with the deep facial vein forms a common facial vein. Deep facial vein is also known as anterior division of retromandibular vein, which is here. This is our deep facial vein. So through the deep facial vein to the pterygoid plexus of vein to the emissary vein going to the cavernous sinus. This infection can take either of the route, through the superficial facial vein or the deep facial vein. Okay. Now this infection is coming to the cavernous sinus, and there the infection erode the endothelium of there. Endothelium, which will lead to thrombosis. And this thrombosis, by the time it increases in size and puts a pressure effect on the content of the cavernous sinus, that if it give pressure over the third, fourth and the sixth cranial nerve, that is supplying the extraocular muscle. All the extraocular muscles are supplied by the oculomotor nerve except the ASO4 and the LR6, that is the superior oblique is supplied by the trochlear nerve and the lateral rectus is supplied by the abducens nerve. So all this, that is the 3, 4, 6, the cranial nerve involvement will lead to the external ophthalmoplegia, that the voluntary muscles will not act The eyeball muscles will not act. Okay, and there is external ophthalmoplasia will be there, and there is backward pressure, backward venous pressure due to the rise within the pressure within the cavernous sinus. There is a backward pressure over the orbit through the superior ophthalmic vein and the inferior ophthalmic vein. There is a venous congestion backward, which will lead to the engorgement of the eyeball as well as the exophthalmos. The eyeball will protrude out due to the effusion inside the soft tissue. Okay, and due to the congestion of the central vein of the retina, and that will lead to the blindness. And involvement of the 5A and 5B, that is the ophthalmic and the maxillary division of the trigeminal nerve, which is a purely sensory nerve. There will be severe pain by the side of the forehead and the eye and the maxillary region, that towards the maxillary prominence and the lower eyelid and the upper eyelid, forehead, all are supplied by the sensations are carried out by the ophthalmic division. So ophthalmic and the maxillary division of the face, there will be severe pain over there. So these are the sign and symptom of the cavernous sinus thrombosis, and it travels to the dangerous area of face. Now coming to our second applied anatomy, that is the caroticocavernous fistula. Caroticocavernous fistula. There is a fistula in between the internal carotid artery and the cavernous sinus. As internal carotid artery run within the cavernous sinus, if there is a fracture of base of a skull, there will be a rupture of the wall of the internal carotid artery, and there is a mixing of arterial blood and the venous blood inside, as well as the necrosis symptoms. There will be ischemia of the content, the nerve, and all this, everything, the sympathetic nerve, parasympathetic, all are supplied by the few branches from here only. So they will show the ischemic sign, as well as the pressure symptom will be there, as well as there is a there is pulsation inside the carotid artery, which regulate the blood flow inside the cavernous sinus. There are two factors which governs the blood flow inside the cavernous sinus. One is the pulsation of the carotid artery, and second is the our posture of the head and the gravitational force. Okay, so when there is a rupture of the internal carotid artery, there will be blood leaking inside that, and there is the increase in pressure, and the same symptom will occur, that is the external ophthalmoplasia due to the involvement of third, fourth and sixth cranial nerve, as well as the engorgement of the eyeball due to the backward blood flow, venous congestion, as well as the severe pain by the side of the forehead and the lower eyelid, upper eyelid, the maxillary side, ophthalmic region, all where. And in addition to that, there will be pulsating exophthalmos, the pulsation of the internal carotid artery that will transmit to the eyeball, and the eyeball will come out, then go backward, forward, backward. This is called with the pulsation of the internal carotid artery, because pulsation is now not limited to the internal carotid artery. Due to the rupture inside the cavernous sinus, there is a mixing of arterial and venous blood, and there is a backward venous pressure that will lead to the propulsion and the repulsion of the forward and the backward movement of the eyeball. So that is called the pulsating exophthalmos. As well as there will be loud bruit. We can hear the loud bruit over the eyeball.